Okay, thank you very much, François, for your invitation. It's a great pleasure to be here, and I'm very impressive to speak after Ms. Kinnan, because my experience is not the same. But I want to explore with you today the idea to use a new transfer, the Peroneus Longus Tendon transfert, for the correction of spastic varus foot deformity. First of all, I want to thank my two mentors for coming in Martinique a few years ago. First, Yves Allieu, 15 years ago, who introduced me the neurosurgery with tetraplegia, and after Philippe with hemiplegia, and thank you, François Genet, and also my friend Bertrand Coulet. So I will focus my talk on the surgical aspect of the choice of the tendon transfer to treat the dynamic varus, varus reducible, not fixed varus. And the aim is to restore and maintain in the time a stable and plantigrade walk with several transfers. By my talk is which tendon we have could be the best tendon to treat the varus due to the hypertony of the tibial anterior. Next one. So three procedures already are described in the literature to treat the tibial anterior dynamic varus. Two use the tibial anterior tendon, and one use peroneus brevis. The first, the most used procedure in the world is the splat, where Ms. Kinnan has already talked. And we divide the tibial anterior tendon to obtain a better equilibrium in the frontal plane and to treat the varus. And this transfer is combined with several procedures with Achilles lengthening, two flexor tenotomy, posterior tibial lengthening sometimes, transfer of extensor hallux tendon proposed by Kinnan, and anterior transfer of the two flexor proposed by Ono. The second procedure is the lateral transfer of the entire anterior tibial tendon on the lateral cuneiform, first described by Garceau and Ponseti, and used by Ponseti for the congenital clubfoot, and is used in France by the Montpellier team with Asensio, who report good results. But you use the entire tendon, and you deplace the tendon on the lateral dorsum of the foot. But this technique is very little used, because probably because the negative points, the tension adjustment is not easy. There is a risk of losing the benefit of the hypertony of the anterior tibial tendon if you have a problem of fixation. And there is problem of fixation with anchorage problem in osteoporotic bone. And you have a problem with the pain and conflict between the scar, anterior scar, and the shoe. The third technique is a retrograde fixation of the peroneus brevis tendon onto the anterior tibial tendon, first described by Bardot in 1989, and used by the Marseille team by Curval, and with also report a good result. The technique, you make a tenotomy of the proximal tendon, and you transfer the distal tendon with the suture of the proximal part on the tibial anterior. So this technique, the advantages of this technique are numerous. You have no risk of weakening the tibial anterior tendon. you obtain a greater tendon transfer, so stronger with two tendons. And there is no problem of fixation because you have no bone fixation, and in osteoporotic bone is a good thing. And the author make a solid pulver-taft suture we use in hand surgery. But this technique is very little used. Why? Because you have big disadvantages. Is Philippe saying me the first disadvantages, and I have observed in my experience. This is the conflict between large sausage scare anterior with the shoe. And it's difficult because the peroneus brevis tendon is brevis, is short, and it's difficult to to get proximal the scar on the leg. But it's very interesting to know that several authors who use a splat technique, when they have a problem, perioperative problem with the splat technique, they use this technique, this Bardot procedure. So when you divide a tendon in splat technique, you inevitably weaken it. And there is some negative point of this technique. And complication in the literature, you have cuboid fracture with the tunnel. Tensioning in a balanced position is sometimes difficult. You have a risk of screw pull-out in osteoporotic bone. And the lateral limb of the anterior tendon is much smaller and weaker than a peroneus tendon. So, there is also a risk of decreasing the function of the tibialis anterior. And this technique, you have a lot of system of fixation, a lateral cuneiform cuboid with a tunnel, same tunnel but with transplantar fixation, tunnel with interference screw, tunnel with staples and bypassed the peroneus brevis tendon. And the last one in Besançon as a suture to the peroneus brevis tendon. So this is a difficulty of this technique, but the author observed only 5% of detachment of the graft. So why we decide in 2006 to use the peroneus longus as a transfer? The reason was to preserve the tibial anterior tendon first, to have no scare and conflict with the shoe wear, to obtain a solid transfer, and to avoid the problem of bone fixation in osteoporotic bone. But mostly, the most important reasons are anatomic reasons. Because peroneus longus tendon is significantly much longer than peroneus brevis. And you can make a suture with a scar, as you can see here, very proximal, 15 centimeters above the ankle. So no cicatrice with no scar with shoe. The second reason is we have progress in our technique of tendon suture. It's not necessary more to practice pulver-taft suture, which gives sausage cicatrice, very voluminous cicatrice. And this paper shows that with a side-to-side, very flat suture, it's stronger than pulver-taft and with a better scar. A second aspect is the anatomic aspect. The most interesting thing, in my opinion, that the insertion of peroneus longus tendon and tibial anterior tendon are exactly the same, but in mirror. Peroneus tendon on the plantar side of the first metatarsal base and medial cuneiform. And for the tibialis anterior tendon, it's the dorsal part of the first metatarsal base and medial cuneiform. So those mirror insertions, we can hope that it could be the ideal transfer to treat the varus. The second, last but not least, the physiological action of this muscle. Peroneus longus is a plantar flex muscle and invert the foot. And when you transfer the peroneus longus on the tibial anterior tendon, you convert this physiological action in a dorsiflex and invert the foot. So it could be an ideal transfer to restore some active dorsiflexion, which is not possible with hemi-tibial anterior or peroneus brevis. So the surgical technique is very simple. We have three approaches. Three approaches. It's very simple. A small incision to isolate the peroneus longus, lateral distal, lateral proximal to make the tenotomy of the peroneus longus. After you transfer subcutaneously the tendon and you make a suture it's a key point in maximal tension of the peroneus longus, as you can see here, foot in maximal eversion and 0 degree flexion with a minimal tension of the tibial anterior tendon, which is slack. And postoperative care is a working cast for 45 days. You can see the absence of scar here and the very proximal anastomosis. Here you can see the subcutaneous tendon transfer of the peroneus longus. So we have presented at the French Society 2 years ago our preliminary result. I have operated 25 patients, but we have only reviewed 10 patients. It was indication with a varus echinus foot, with a reducibility of the varus, and the best case was with Struppel maneuver positive, as you can see on the slide. 3 complementary procedures was done, 6 Achilles lengthening, 7 2 flexor tenotomy, and 2 Dwyer osteotomy in case of severe varus. The criteria of evaluation was classical. We measure the tibio-calcanean angle, ankle mobilities, T90 working score, and secondary criteria were examination of the patient walk, patient satisfaction, use of equipment, orthosis, orthopedic shoes, cane, and looking for complications. So the results was good correct of the varus in all the patients with no recurrence. And we have observed a restoration of good active dorsal flexion in 4 cases. Improvement of echinus was 15 degrees. Average improvement of tibio-calcaneal angle was 15 degrees. All patients have reduced their equipment, as you can see on this slide, and all patients have improved their working distance. The patient satisfaction, all patients were satisfied or very satisfied with an average index at 4 and 5. All patients would recommend this procedure to a member of their family or friend. Complications in this series reviewed by Marine Detienda, we have only no infection, no hematoma, non-conflict scare. 3 patients complained for 2 claws. But recently, I have a rupture of the anastomosis with a combined posterior varus, and I make a transfer of posterior tibial on the fibularis longus with good results. So now I show you some video. You want José to?
Yes. So I'm a PMR doctor, and we work together in Martinique to try to build a unit of neuro-orthopedic between us, surgeon and PMR. And then with the patient that that had been operated of this transfer, we can see that we have a benefit on the active dorsiflexion during gait, and we have a good. If we are not in the good point of view to see that, but we can see that the posterior part of the step is preserved. Then we have a good perspective to work with the patient to get back the use of the propulsion phase during the gait, because those patients with the equinovarus don't use so much this part of the walk because of the lengthening of the member, and the fact that we have more dorsiflexion let us hope that we can reuse this flector, this flexion part of the gait, and use more propulsion and have a better symmetry during the gait. And we can see that we have a correction of the equinovarus, more use of active dorsiflexion, and a better use of the posterior part of the gait with those patients.
It's another patient with extension gait pattern.
Yes, those the gain we have in the active flexion is more important during the gait for the patient that had a better hip flexor or knee flexor to preserve the symmetry and the efficacy of the gait. And the more we had this active flexion of the hip and the knee, and the more we have a better result for those patients. And for some of the patients that when we can observe only automatic contraction of the tibial anterior, we have less good result because it was more difficult to use this part of the gait when they start the hip flexor to have the automatic contraction of the tibio anterialis, and then we have to work on this part.
And on this case, you can observe the dorsal flexion active with the peroneus longus there. Another case with balance disorder. Okay. This case. Tac. This. And this one. And the last one.
But we see in the gait that sometimes we still have a flexion of the forefoot. Even if we reach better active dorsiflexion, we still have in the forefoot, in when the foot leave the floor, we still have a tendency to the forefoot flexion, maybe because of the flector digital flector.
And you can see another case with the dorsiflexion active restoration. And the last one, where we can see the two tendons. Thank you very much.
you.